Well, hello and welcome to week 4. This week we'll be discussing nurses and the law. So the law is quite interesting. We all have big ideas of the law and the consequences of the law in terms of our day-to-day lives. But this week we'll be focusing on the role of the law in our professional practice as nurses. The little cartoon nicely captures some of the ideas about law. Marketing says yes, and of course legal says no. We have a certain wariness or a certain concern about the law in that it is more cut and dried, and we are often quite aware of the very serious negative consequences should we break the law. And so this week we'll be focusing on understanding how the law influences our practice and what happens when our practice falls outside of the boundaries or what we as a society have decided is a lawful practice. What's important to understand here is the law is not something that is static. The law is something that is dynamic, and it's really the public's instrument for converting morality to clear-cut guidelines and stipulating punishment. So what is interesting is that as our society evolves, laws are created or laws are changed. And the laws are a very public instrument for us to understand, what is allowed and what is not, and what contributes to the greater good and what contributes to the harm of society. In my opening comments, for example, I gave the example of abortion. A number of years ago, it was against the law to have an abortion, and there were punishments attached to those who had them and those who provided them. However, morality and our ideas of what is for the common good and what is part of a good and just society, those ideas changed over time, and so too did the abortion laws. While not everyone would agree that abortion is a moral act, as a society, we have decided that having abortion as a legalized practice is for the greater good and is therefore a legal act. So it is important to recognize that laws do change and that they reflect the contemporary society's views. Okay, so you've been looking at my attempt to create a visual display of what we've been doing in this course. So in week 2, we spent time looking at the normative ethics. So we talked about utilitarianism, deontology, virtue ethics, bioethics. Last week we added in feminist, relational, care, and narrative. And this week, into the funnel, we're adding our understanding of the legal system. So what we're trying to do here is really the same thing week after week. I've been trying to give you various tools so that you can understand what is happening in your context, to help you with your ethical sensitivity and to help you have a variety of perspectives so that you can explore a situation and that you can make the best decision. And really what makes these things come together is our ability to think and is our ability to discern and our ability to really reflect on what is happening in our midst. And going back to an earlier statement that I made to you, it's seldom our first thought that is our best thought. It's usually our last. So we are asking you to think very deeply and very extensively about these topics. So in terms of the goals and objectives for week number 4, as I mentioned earlier, it really is to explore the legal system and the legal analysis and how these influence an assessment of negligence in nursing practice. So we need to understand where our boundaries lie, and when we fall outside of those boundaries, what happens if we have negligent practice or practice that harms another. So we need to also understand and explore how the law influences ethical nursing practice, remembering that laws are society's way of codifying what is ethical and what is good. We also, in our time together, will examine some of the consequences of failing to meet the standard of care, and really to clarify our legal duty to care, because we do have an obligation as nurses. We do have duties, and there are consequences when we fail to adhere to our duties. We're also going to look at how the law can be used to promote ethical practice and also to clarify the limits to the law. And we're going to spend some time recognizing and managing legal risks in our practice. We'll talk about some of the readings for this week, and we're going to begin exploring the ethical decision-making models. There's one in your textbook designed by Oberle and Raffenbushel, and there's a different model from Jan Storch. Remembering I spoke to you last week about Jan Storch. She is an ethicist from British Columbia. And she has a model that many of us who teach ethics actually prefer. And so in your course documents, you will see this decision-making model, and we'll have an opportunity to discuss that as well. So there are several laws that influence us as nurses. The following list just names a few, but it is important for you to understand the laws that are inherent in your practice. For example, I think we're all fairly familiar that as registered nurses, we have an obligation to report child abuse. We have an obligation for domestic violence reporting, gunshot wound reporting. For example, if you're a nurse in the emergency department and somebody comes in with a gunshot wound, our normal patterns of confidentiality change, and we are obligated to report that. Sexually transmitted diseases or sexually transmitted infections, we have an obligation to report those and to do contact tracing. And it's very interesting. There are many laws that influence our autonomy. And again, we see how they're contributing to the greater good. So for example, there are laws against smoking in a car when there's a child present. Children must use child restraints. We see a number of public health nurses involved in helping safely install child restraint seats in a car. We know that if somebody is threatening to commit suicide, we have an obligation to break confidentiality and disclose that. We have the right under certain conditions to confine people. For example, people who are harmed to themselves or to others, we have the ability to confine them and to admit them against their will for treatment. And the list goes on and on. It would be interesting for you to take a moment and to think, pause the slide, and to think about the laws that are inherent or that influence your current practice setting. Okay, I'm just going to do a little bit of disclosure here and tell you something you already know, and that's I'm not a lawyer. I think if this discussion were being conducted with a lawyer, it would probably be quite different. So you have my interpretation and the best of my abilities to try to explain the various types of law. So here goes. So this again is one of those slides that helps you to study or helps you to sort of have a summary of the week's discussions. And so we'll be talking about these various types of law as we move through the PowerPoint and the little mini presentation here. But what I want to draw your attention to is that there are a variety of types of law. There is the law under which healthcare is practiced, and these laws are created to protect the public. So for example, once you become a registered nurse, you will be practicing under the Regulated Health Professions Act, there's the Canada Health Act, there's the Public Hospitals Act, the Nursing Home Act, and so on. But in particular to us as registered nurses, the regulation law, such as the Regulated Health Professions Act, is actually the law that allows us to be registered nurses and to practice with autonomy and to be self-regulated. But as you've heard me say many times, we get this self-regulation in exchange for our duty to protect the public and to adhere to the standards of practice. And so the areas of risk here is that if we're practicing nursing while impaired, or if our practice is falling outside of the standards of practice, we know what those standards are, and there are consequences for that. So we'll discuss some of those, and actually I'll draw your attention to some very interesting examples of what happens to nurses whose practice falls outside of the standards. Then there are laws of malpractice or tort laws, and those are really designed to discourage harm. So examples of malpractice or tort laws are negligence, intentional or unintentional negligence, and it's person-to-person harm. So the area of risk here is that you would be performing a lawful act, but you would be doing so in a careless manner that does not meet the standard, and that something actually happens to the person as a result of that. And so here we have intentional and unintentional problems with the law. Intentional is if we actually assault somebody, but we can have unintentional harm, which comes from negligence. So we'll speak a little bit more about that throughout the discussion as well. And the last is that are the criminal laws. And these are also designed to discourage harm. And for example, if you were to steal from a patient, that would be a criminal act. And so basically, there's a long, long list of criminal acts that are listed in the Criminal Code of Canada. And if you commit one of those acts, then it falls under the type of law called criminal law. And basically, the thought is that we have an obligation to know what is criminal and what is not, and to act within the what is not list. So why should you care about the law as aspiring nurses? And really, the law can help us to enact ethical practice, and it can also help us to regulate ourselves and to have understanding of what falls within society's beliefs about what is lawful and what is not. It also gives us another framework for ethical practice, and so I'll draw your attention back to that funnel diagram. It also lets us know what will happen to us if we fall outside of a legal or a lawful practice. So we know that if we commit a criminal act, we can know with a fair degree of certainty that if we're caught and convicted, that there is a consequence for that. And there's even a parameter of what kind of punishment would happen to us, depending on what law we broke and to what severity. We also know that if we're doing things that are negligent or things that cause harm to others, we know that our practice is falling outside of the realm of what is acceptable and that there would be a consequence for that. The other part about the law that is interesting, that it sort of begins to set out for us our legal obligation to our patients and our corresponding rights. So remembering my earlier remarks that in exchange for being self-regulated and being autonomous professionals, we have certain obligations and certain duties that we have to fulfill. So at the bottom, I'm making reference to the Keatings and Smith textbook. I believe it's available in the library. And Keatings is a nurse, and I don't know whether she still is, but she was the chief nurse at the Hospital for Sick Kids. And she is considered to be an expert on the law in nursing. And so if you're interested in this area, or if you're deciding to explore this area in some of your written work, I would certainly encourage you to read portions or all of that textbook. One of the other aspects in terms of knowing our rights and responsibilities is understanding our accountability under the Canadian Nurses Association value statements. So if you recall last week I mentioned that in 2008 the CNA revised the Code of Ethics for registered nurses, and this is the Code of Ethics that we all adhere to, all nurses within Canada. There are similar obligations that are delineated through the College of Nurses of Ontario, but basically nurses, as members of a self-regulating profession, practice according to the values and responsibilities in the Code of Ethics for registered nurses, and in keeping with the professional standards, laws, and regulations supporting ethical practice. So the code makes very clear that we must practice ethically and that we must maintain professional and legal standards and rules. So in work such as nurses' work, it's not anything goes. We have a very tight framework in terms of our obligations and our duties. And a part of our job in nursing education over the next 4 years is to teach you about those responsibilities and those obligations and those duties so that you are fit to practice. And part of your job as students is to work hard in learning this and ensuring that you ask questions and that you ensure that you have adequate knowledge, practice, skill, and judgment to be able to adhere to these standards. So what I'm trying to do in this slide as I'm trying to show you the complex web of laws that influence nurses' work. One of the promises that I made to you in terms of the goals and objectives is that you would begin to explore the influences of law on nurses' practice and how this fits within our social contract that we have with the public. So there are many different laws that influence our day-to-day practice. For example, the RHPA, the Regulated Health Professions Act, is in fact the law that allows us to be self-regulated. It's the law that allows us to attribute consequences to one another should our practice fall outside of the standards of care. For example, if you turn to the back section of the standard, that's the monthly journal that comes out from the College of Nurses of Ontario. In any given issue, you can see instances where nurses are being punished for nursing practice that falls outside of the standards of care. And so that becomes then the consequence of that becomes decided by in terms of other nurses making decisions about what is a standard of practice and how seriously that person deviated from the standards and what should be the consequence for that professional misconduct. And then we also have a social contract. So we have certain obligations. We have rights and responsibilities that we fulfill in exchange for the rights of being self-regulated, but also in holding ourselves out as professionals. So for example, we have the CNA and the CNO Code of Ethics or Standards of Ethics. And again, because we're self-regulated, it is nurses setting these standards. And again, if we fall outside of that norm, we can be punished in terms of professional misconduct. And we also have the laws that, because we are part of the general society, and our work certainly puts us in a position to cause harm to others. And the privileged position that we have enables us, should we be not practicing lawfully, to cause harm. So basically there are the tort or the criminal laws that come into play. And again, here we can have either a criminal conviction or we can have consequences from malpractice. In terms of malpractice, those would be lawsuits that we're quite familiar with. Our society in Ontario is certainly not as litigious as that in the United States, but there are still instances where health professionals are sued and successfully sued, and damages are paid to the claimant. So really, these various legal systems set the standards and the measures, and they help us to discern the performance and behaviors of nurses against the standards set by nurses, and were measured against the practice of other nurses. So what would a reasonable nurse have done in this same situation? That is often the measure that our practice is based against. And if our practice falls outside of what is reasonable and what is expected, we are punished. Either we're punished through the court system or we're punished through the disciplines hearing system of the College of Nurses. So I really like this question. What is our legal duty to care? So often in our curriculum, we talk about our moral obligation to care, or we talk about a calling to care, or a sense that it's a conviction, or that we're just naturally so. But in fact, we also have a legal obligation, a legal duty to care for others. So you're probably hearing quite a strong sense here of deontology involved in this segment of my conversation with you. So here, some of our legal duty to care is that we cannot place others in peril as a result of our conduct. So we must always be quite aware of what we're doing and the consequences of our actions. And we cannot create a hazard, even unwittingly. So what you're hearing here in these first two statements is a strong obligation toward knowledge-based practice. And in fact, the level of knowledge that is required of a registered nurse is a deeper and broader level of knowledge to that required from a registered practical nurse or a healthcare aide, for example. And so you are responsible for ensuring that you have the knowledge, skill, and judgment to enact your legal duty to care. And it's quite a high standard. So we must have a very high degree of care when carrying out our tasks because of our education and training. And so again, as I mentioned in the previous slide, our measure is what would a nurse have done in a similar situation. So we are measured against one another. So it's interesting here when you're a student and you think about how you're carrying out your academic responsibilities. So if you're always falling in the low side of the class average, you have to know that when you start practicing as a registered nurse, you will be held to a duty or to a standard of care of the average nurse in a typical situation such as the one that you're in. And so if you're always practicing with below average knowledge, you're actually exposing yourself to legal risk. Okay, so what I thought I would start with then are some of the laws that come out of the CNO. So these are our professional standards of practice, and there are 37 acts of professional misconduct, and they're set out by the Nursing Act in 1991, and there are constantly revisions to the Nursing Act. But some of the examples of professional misconduct include contravening or failing to meet a standard of practice of the profession, directing a nurse or nursing student to perform a nursing function for which he or she is not prepared or competent to perform. This is very important for you as students in terms of a nurse asking you to do something that you're not competent. In fact, that if you tell that nurse that you don't know how to do something and he or she tells you to do it anyway, that is in fact professional misconduct on that nurse's behalf. Any act that involves verbally, physically, emotionally, or sexually abusing a patient is professional misconduct, or practicing nursing while one's ability to do so is impaired by drugs or alcohol. And please remember this last statement when you start working with Kathy's story in the case study in terms of professional misconduct. So most noteworthy then is engaging in conduct or performing an act relevant to the practice of nursing that, having regard to all the circumstances, would reasonably be regarded by members as dishonorable and unprofessional. So remember that you're held against the standard of what a typical nurse would have done in that situation. So if your peers, because we're self-regulated, if your peers deem that to be dishonorable or unprofessional conduct, then it is. And so these are the situations that we read about in the back section of the standard from the College of Nurses. So just to emphasize a point here is that we do have a statutory or a regulated duty of care. So through the RHPA or through the Nursing Act, we have explicit or implicit duties that we owe to patients. And among those, for example, is the duty to report nurses who display lack of proper skill, judgment, knowledge, or training. I think it would be very interesting for you to pause for a moment and to think about how is this actually enacted in practice? How do we actually support one another to practice to the best of our abilities? And I think it would be quite interesting for you to also examine your own reactions and your own practices within this duty. So for example, within your clinical group, how are you acting toward your colleagues or your fellow classmates who have questionable skill, knowledge, or judgment? How are we working within that system in terms of nursing education? And I think it's quite interesting because the way that we enact some of these duties in nursing school go on to influence the way that we enact these duties in our practice. And it's a very, very complex duty that we carry out. And as you'll see again in the case study that I selected for this week, it really brings to light just how complex and how interwoven our sense of commitment to one another as human beings, our commitment to one another as nurses, our commitment to our patients, and how these various duties and obligations intersect, and how they actually create tensions, and how it's not as clear-cut as, for example, Kant would think it to be. We also have a duty to report a nurse who is under the influence of drugs or alcohol, or any other kind of influence that would be impairing his or her practice. Okay, so what I've been talking about then are the legal obligations and our moral and ethical obligations that have been codified through the Regulated Health Professions Act to the Nursing Act, all the way to the College of Nurses of Ontario and the CNA that direct our practice and that sets out the punishments should our practice fall outside of the standards of what a typical nurse would have done in that situation. And we're making a shift now. Okay, and so we're making the shift here now to the other forms of law, for example, the civil and the criminal system. So these are the laws that affect all people, not just registered nurses. So as registered nurses, we are part of the public, and so we also are influenced by the laws of the public. And so we're influenced in our practice by tort law and by the Criminal Code of Canada. So I'm still trying to answer the question that I posed to you, what is our legal duty to care? And so we've talked about our legal duty to care in terms of what has been set out through the RHPA and the Nurses Act. And now I'm talking about our common law duty of care. So the nurse is legally required to operate and act at a level that meets or exceeds the standard of care that a reasonably prudent health professional would provide. So that meets or exceeds. So that reconnects with my statement. If you're always practicing below average, then you're actually exposing yourself to some risk once you become registered. But this common law duty of care implies that the nurse must participate in continuing education. We know, and we've probably said to you 100 times now, what we are teaching you now is going to be outdated in a few years. And so with the pace with which new knowledge is generated, it is completely assumed and expected that you will have to participate in continuing education. It does get a little easier because you will practice in a specific area of nursing, and so you won't be keeping every area of nursing updated. But for example, if you work in pediatrics cardiology, you will be required to maintain current knowledge related to pediatrics cardiology. Okay, so the Criminal Act and the malpractice or negligence or tort laws are the kinds of laws that influence everybody within Ontario or Canada. And so as nurses, we fall under those laws as well. So a criminal act, for example, the action must specifically fit within those listed in the criminal code. And as I mentioned, there are about 600 listed. So if you've done something and it fits within the criminal code, then you would have committed a criminal act and you will be tried and punished according to that court system. So for something to be a criminal act, it has to fit within one of those 600 listed, but you also must have had intent, or you should have known that harm could come. So these are extreme omissions or recklessness. So it is very uncommon that nurses are actually charged under the Criminal Act, usually because of that idea of intent. And it really, that extreme nature needs to be present. So here the standard of proof is beyond a reasonable doubt, and the goal of the Criminal Act is to protect the public so harm does not have to occur. So an example is drunk driving. So we know that when we get into our car and we've been drinking, that we know that we are impaired and our ability to drive safely is impaired. So while our intent might not have been to harm somebody, we should have known that drunk driving had a high risk that somebody would be harmed. And so that's why it falls under the Criminal Act. And so all of the decisions, unlike professional misconduct, those are handled through the College of Nurses. All the legal issues around the Criminal Act happen within the court system. And so the tort laws, or the malpractice or negligence, this is when we perform a lawful act. So when we're doing something that we're actually allowed to perform, but we do so in a careless manner that does not conform to the standard of practice, and that harm actually happened. There was an actual consequence to our careless manner. And so it's not necessarily individual to individual, and it's not codified. So here the standard of proof is different. So the standard of proof is the balance of probabilities, and the standard comes from the duty to care, so what a reasonable person would have done in the same situation. So if it's an intentional, that would be assault or battery, which again happens very infrequently with nurses in the healthcare system. But there is unintentional tort, and that is negligence, where we just failed to do our duty, or we failed to practice to a standard that would have prevented harm. And so the goal here, and we worry about negligence and malpractice, and the goal is is to prevent violence or harm by making the perpetrator liable. So we sometimes are motivated by our fear of a lawsuit. We sometimes up our game a little bit out of concern for malpractice or negligence. And again, the decisions about whether our behavior or our actions or our lack of actions were out of negligence or malpractice, those decisions are also made within the court system. So the criminal law imposes serious consequences for nurses who act carelessly or recklessly. So the Criminal Code of Canada states everyone who undertakes to administer surgical or medical treatment to another person or to do any other lawful act that may endanger the life of another person is, except in cases of necessity, under a legal duty to have and to use reasonable knowledge, skill, and care in doing so. Okay, so the criminal law standard of care then is quite interesting. If we hold ourselves out as nurses, we are then judged as a nurse. And if bodily harm happens, you're judged against what another nurse would do in that situation. So this is quite interesting. So when we're at work working as a nurse, it's really quite simple and clear cut. We're obviously employed as a registered nurse, and we're working within that system. But what is interesting is when we move into the public domain. So if you're having dinner with friends and somebody asks for your opinion and you hold yourself out as a nurse, as a registered nurse, and you give inaccurate information and harm happens, you are held to the standard of care of what another nurse would have done in that situation. So it's very important that we recognize the limits of our knowledge, skill, and judgment, because if we hold ourselves out as a nurse, the public then assumes that we have the knowledge, skill, and judgment of a nurse. And if we're providing information or advice or treatments, we're doing so as a nurse. Okay, so there's also criminal negligence. And so this is a wanton and reckless disregard. So when someone knows or should have known that acting in a certain way would cause harm, then it can be criminal negligence. Interestingly here, ignorance is no defense. So you can't go ahead and do something as a registered nurse and just say, oh, well, I didn't know. You really are responsible for your knowledge, and you're really responsible as well for what you don't know and for speaking up. So everyone who undertakes to do an act is under a legal duty to do so with knowledge, skill, and judgment. However, there are instances where omitting to do the act is dangerous to life. And here the rules might change a little bit. So this becomes extenuating circumstances where if there is no one else to perform tracheostomy, then perhaps if for sure the patient would die if the act was not performed, then the rules change a little bit if someone does their best in that circumstance. But again, you're measured against what somebody else would have done in that situation. And if you're in a work setting where you should know something and you don't, then it falls back into that reckless disregard. So failing to perform an act can be criminal negligence, or doing an act in a wanton or reckless way can be criminal negligence. And so really, for something to be criminally negligent, it has to be a marked departure from what a reasonable, competent nurse would have done or not done in that situation. So again, it's uncommon that nurses are found criminally negligent. And so for something to be deemed as criminally negligent, it must cause death or harm. Intoxication is no defense, and budget cutbacks are no defense. So it's quite interesting. We're held to quite a high standard. And it's interesting in particular with regard to our working conditions, that it is no defense, is that we don't actually as nurses have a lot of control over the number of nurses that are hired per shift, for example. And yet we are expected to maintain a high level of care within very difficult working conditions. So this is my last slide on criminal acts. So criminal acts are harmful to society. And so the Criminal Code of Canada was created out of society's wish to decide what was right or wrong and what contributes to the common good. So the 600 items that are in the Criminal Code are thought to be acts that are harmful to society. So for example, it is a criminal act to falsify a narcotic record. It is a criminal act to fraudulently bill or to injure a patient or to steal from a patient. And so when something is thought to be a criminal act, it is investigated by the police, it's prosecuted by the Crown, and punished by the court system. So as nurses, we're quite interested in knowing what is negligent. So our practice or conduct is negligent when the conduct falls below the standard of what a competent person acting reasonably and responsibly in a similar situation would have done, and that a reasonable person could have foreseen the ensuing damage. And really, a lot of the decisions with regard to negligence are determined by expert testimony. So you may find yourself in a position once you're a registered nurse and you develop some expertise that you can actually put yourself on a list to be an expert witness. And that's where you would talk about what you would have done in a similar situation, and that's used as a measure. So the CNO sets the minimum standard. So those 123 competencies that we've been working with you to develop competencies within those areas begin to prepare you to meet the minimum standards set out by the CNO. And so if you're struggling to meet those, it suggests that perhaps you would be struggling to meet the minimum standard, again putting yourself at risk. So furthermore, hospital policy also sets standards. So you take quite a risk when you practice outside of hospital policies, because it is viewed that those policies actually protect the patients and the public and the staff. So if you make a decision not to follow hospital policy, you're putting yourself at risk, because it is expected that staff will follow policies. And if, as I've mentioned before, you have a requirement to maintain your competency, and if you're not doing so, then you're not putting yourself in a position to be able to act responsibly. Okay, so I've mentioned to you already that there is intentional and unintentional tort. And so intentional tort would be battery and assault, invasion of privacy, slander, or false imprisonment. Those are all areas where we intended to cause harm. So for example, if you hit a patient, that is an assault, and that is an intentional tort. If you invade somebody's privacy, so for example, if you disclose personal information about a patient, that is an example of intentional tort. So you've done this, in fact, on purpose. An area that I think is also quite interesting to think about as you move into the world of nursing is the idea of slander. And so if you're saying negative things about people and it's actually not true, that is slander, and that also is intentional tort. So you're causing harm to somebody and someone's reputation. This will be quite important for you to think about and to pause and to really consider when you're talking about your professors, when you're talking about your colleagues, when you become a registered nurse, the way that you speak about nurses, the nurses with whom you work. It is quite important for you to consider the idea of slander. So a part of what we have as registered nurses is our reputation. And if people are making false claims about us, it actually causes damage to our reputation, and you could be liable for slander. And the other type of tort is this unintentional tort. So this is still where there's negligence and a failure to meet the duty of care, but here intent is not needed. So there are three key elements that must be present to be liable for negligence. And the case on page 196 gives a good example of this. So the first of the three key elements is that there was a duty of care owed to the patient. So if you're assigned to a patient, then you have a duty of care that is owed to that patient. So there has to then be, as the second criteria, there has to be a breach of duty of care by the nurse, by failure to administer a treatment or to provide health care in accordance with a particular standard of care. So you had to have failed to do your duty. So the first is that you owed a duty to that patient. The second is that you failed to meet that duty. There was a breach of duty. And the third is that the patient suffered damage as a direct result of this breach of duty of care. Okay, so that concludes some of my comments made about the law. We're going to be moving into the discussion about how we minimize our risk and how we work within the risks that are inherent in the work of the registered nurse. I would hate for you to leave this presentation feeling fearful. In fact, there are so many common sense things and common things that we can do in our practice to minimize our risk for having issues with the law. And in fact, very, very few nurses have troubles with the law. And that's in part because we know how the law influences our practice and how we can use these laws to ensure that our practice is meeting the standards set out by the public. So there is a case study in the activities for this week. It's called Kathy's Case. And this is a story of a nurse who is coming to work intoxicated and having consumed alcohol. And so the case study walks you through some of the issues that we've discussed earlier in this presentation. And there are some questions at the end that can help you integrate some of this content. So shifting gears a little bit, but not too much, because we're still talking about how we make ethical decisions. And really the view is that by and large, an ethical practice is a legal practice. However, I think probably from your own work setting and from the discussions that we've had so far, you can see that sometimes what is good might actually not fall within the realm of what is legal. And so it's actually quite complex. So for example, in Canada, it is against the law to euthanize a patient. And that is still viewed as a form of murder. And so it's quite interesting because we might have thoughts about what is good is really to be able to have a practice that enables euthanasia. But the law is still telling us that that is wrong. And so it's quite interesting how our beliefs and values and morals as a society change because there is movement. There have been some court cases that have gone through. In fact, not too many months ago, the Supreme Court of Canada was looking at euthanasia again and assisted suicide. And it is interesting. In some countries, it is legal, and it is interesting to see what will happen in terms of Canada's and Canadians' view on euthanasia. But ethics helps us to understand our moral life as we know it and recognizing that our views of morality change. So one of the questions that I like to ask is if a really caring nurse makes a mistake, is it less of an issue than a less caring nurse makes a mistake? And this is interesting because it raises some of the questions about negligence and malpractice and the working conditions, and mistakes do sometimes happen. And a mistake does not necessarily mean that there is professional misconduct or that there is negligence. So recognizing the difference is quite important so that we're not fearful in our practice and that we're not paralyzed by the worry that we'll somehow have an encounter with the legal system. So there really is a view that if you are doing your best and if you are fulfilling your legal duty to care, you are likely practicing in an ethical and a legal way. So what are the risks of being a nurse, and how can we limit these risks? I am quite certain that you've had discussions with your practicum mentors in other classrooms, amongst each other, with some of the staff that you're working with, about our concern for legal risks. And there is quite a view that legal risks can be managed, and it involves us having an understanding of where are some of the potential pitfalls. Some of the ways that we can limit our risks is that we actually form relationships with our patients and that we form relationships with each other. We know that the way that we work together, either as colleagues or with our patients, creates conditions that actually promote safe patient care. When there is good communication, we understand the needs and we understand the supports that we have for practice. Another way that we can limit risk is that we pay very close attention to the idea of consent. In fact, we're going to have the better part of a class on consent in a few weeks. And consent is either explicit or implied. So written consent in and of itself is not consent. So consent is a process, and at any given time, even when someone has signed a consent, they can withdraw consent, they can change their minds. And so it's very important that we have a relationship with patients and that we understand that at any time they can make a decision to proceed with treatment or to not have treatment. Another way that we can limit risk is that we know the practice standards, that we understand what is expected of us in terms of our practice as nurses. In your 4 years of the BSCN, we are educating you on how to meet those practice standards. And so paying very close attention to that education and working really hard is a key strategy at this point for you to limit your risks. There certainly is ongoing professional development and quality assurance programs. Once you become registered, every year you have an obligation to participate in ongoing professional development and the College of Nurses QA program. And another way to limit risk is to use the documentation system that we have in our work settings, and to be very careful and diligent about how we describe the work that we've done with patients and the patient's response to our care. I just want to reconnect with relational ethics because there is a growing sense in nursing that relational ethics will actually help us to fulfill our social contract and our legal and moral duties to patients. And there is a sense that within the relational space that we are able to enact our morality. We need to consider ethics in every situation, every encounter, and with every patient. So Vanji Burgum goes on to say that if all relationships are the focus of understanding and examining moral life, then it is important to attend to the quality of relationships in all nursing practices, whether with patients and their families, with other nurses, with other healthcare professionals, with administrators, or with politicians. One of the readings that I asked you to complete in this course is by Pavlish and another group of scholars, Pavlish et al. And they were finding common areas where there can be ethical dilemmas. And along that same line of thinking is that when we are forearmed, so when we understand areas where the waters are a bit mucky or the way is a little bit dangerous, we can actually pay more attention or we can increase our focus to try to minimize our risk. So here are some common nursing errors or areas where nurses get into trouble in their practice. And one of the key areas is around miscommunication. And so that's why I re-mentioned the idea of relational ethics. There is a view that when we are in relationship with our patients, when we're understanding one another, that it is actually safe for practice. Another area where nurses seem to run into some troubles is a failure to respond or to treat a patient in a timely manner. And so I want to mention again that the workload is no excuse. So the working conditions will not get you off the hook. The only thing that could possibly help you is that you're measured against expert testimony, for example. But we really have obligations to provide care in a timely manner. Other areas that we get into trouble is improper use of a medical device. So again, it is important that you understand how the machinery in your work setting works and how it's used safely. Failure to identify or treat infections is a common error. And so you can see again where you're held accountable to quite a high level of patient assessment, for example. Performing procedures that you are not trained to do can pose a problem. Typically what happens in the work setting is that if there's going to be a change in practice, if there's going to be a new skill added on, the hospital has an obligation to offer education sessions. And it is actually your responsibility to make sure that you get to those education sessions. So it is a joint responsibility. Another common area is administering the wrong dose or the incorrect medication. And I'm sure that we could come up with a much longer list if we were to spend some time at it. So recognizing these risky areas can help us to focus our practice. And I think it's also important to make the distinction that a mistake is not necessarily a criminal act and a mistake is not necessarily negligence. I think that there is an understanding that mistakes happen in healthcare, but it's back to this idea that you known or should have known, or that there's a wanton and reckless disregard. There's an excellent resource called the Canadian Nurses Protective Agency. I know that this hyperlink won't work, but it's actually in the linked documents for this week. You can log in as a student and your password is assist. And so you can go in as students and look at the various resources from the Canadian Nurses Protective Agency. And once you become a member of the RNAO, once you graduate, you can access these services through your RNAO membership. In fact, one of the activities that I have you do for this week is to go into this website and to look at the resources. In particular, they have little info law documents, and these documents are often just 1 or 2 pages, and they provide a really good summary of your responsibilities and your rights and your obligations within that area. So I would really encourage you to go and have a look. I think it's also quite interesting and important for us to think about the hospital's role in managing liability and reducing the risk of legal problems, because we are typically employees. So here I mention hospitals, but it would be a similar in a long-term care setting, a similar obligation if you worked for in the community for various agencies. So the employing agency has a responsibility to hire qualified nurses. And so now it's a public document where agencies can go in and see that we are in fact registered and in good standing with the college. But it is the hospital's responsibility to hire nurses who are actually suitable for the positions that they're being hired for. And if they're hiring somebody who is not yet suitable, that they provide a sufficient orientation. So when you're brand new grads, for example, if you're hired into an emergency department, it would be the hospital's obligation to recognize that you're not actually qualified as a brand new grad to work in an emergency department until you've had sufficient orientation. And so that is the hospital's responsibility. So they must provide opportunities for education, especially in the specialized areas, such as ICU. And so you will see in most work settings there are nurse educators who are hired to train and to provide additional education. But as I mentioned previously, it's your responsibility to get to those sessions. It's also the agency's obligation to offer safe working conditions. And it's quite interesting because most nurses work under the Ontario Nurses Association, the Nurses Union, and they have forms that they can fill out if they're forced to work in unsafe conditions. And so eventually the hospitals need to respond to staffing levels or to the geography, the setup of the units, because it is their responsibility to offer safe working conditions. It is the hospital's responsibility to create policies and procedures and to enforce them. And so most agencies have policies and procedures. And as I mentioned previously, if you choose not to follow a policy or a procedure, you're really putting yourself at risk. You would have to have a very good reason for not adhering to a policy. You would have to be able to justify and offer a rationale for why you chose to do something different. So if there is a policy or procedure in your work setting that you don't agree with, or that is not current or reflective of best practice, it is important that you take the initiative to make changes to that policy and just not disregard the policy. Another obligation that agencies have is to review performance. Typically, this is done annually, but this is a way for the hospital to make sure that the people that they hired are still qualified and competent to work in that setting. I thought this to be a little interesting slide in terms of the assumptions that physicians are permitted to make vis-a-vis nurses' work. As you know, we practice as autonomous professionals, and yet nurses' work and physicians' work overlap quite a bit. And so it's interesting to know that physicians are allowed to assume that the hospital has hired competent nurses. So physicians will write orders, and they can safely assume that those orders will be carried out by competent nurses. Physicians are allowed to assume that the nurses are able to perform a nurse's job, and that they are able to assume that their orders are being carried out competently. So physicians are, will write orders, and they are allowed to assume then that those orders are carried out as they've been written, unless they know otherwise. So if a physician knows that somebody is not going to carry out their orders, then they have an obligation to do something about it. Or if they know that nurses are not competently able to perform their jobs, they have to do something about it. But unless they know, they are allowed to make that assumption. Okay, so you're set now to move to the activities that we've set out for you this week. And I would also encourage you to look in the back section of the standard, that's the CNO review that comes out, and to look at the discipline decisions. I think it's quite interesting to see the kinds of areas of risk that nurses are finding themselves. I think it's also interesting to look around your work settings where you're conducting your practicum placements, and to use the various lenses that we've offered to you to develop your ethical sensitivity. So join the activities in the discussion forum, and I'll be anxious to read what you're writing.